So thanks to everyone for joining our Q&A session today. I'm Christie from the PBC Foundation, and today joining us we have Dr. Gideon Hirschfield. Thank you so much for joining us today. We really appreciate you taking the time out to be here with us. It has been a wee while since you've joined us, so I just wondered if it might be good to do a wee introduction for our newer viewers, please.
Sure. My name's Gideon Hirschfield. I'm a liver doctor. I'm based in Toronto, and I lead, with my colleague Dr. Guillaume Hussain, a dedicated autoimmune liver disease and rare liver disease program. Currently, in our program, we look after about 750 patients with PBC, alongside similar numbers of patients with autoimmune hepatitis and primary sclerosing cholangitis. We spend a lot of time looking after our patients. We spend a lot of time teaching our colleagues how to look after our patients, and we try our best to contribute to a variety of different research interests in autoimmune and rare liver disease. So I'm pleased to be here to chat with you today.
Brilliant, thank you. Our weekly Q&As continue to be as popular as ever, which is brilliant. But I do have a wee bit of housekeeping that I'd just like to cover at the start of the call as well. So please remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. We'll generalise your questions to support that. So if you need help with a more detailed issue, then please give us a call in the helpline. I'll be recording the session here in Click Meeting, so just be aware of that, which we'll upload to our YouTube channel. But for our attendees here, the right-hand side of the screen here, where you can see attendees and any text in our chat box, that part of the screen is not recorded, so that's a private space whilst the Q&A is taking place. So I'll get started with any questions that we've had sent in. If you've got any live questions for us, pop them in the chat box and I'll pick them up. So the first couple of questions that we've had in, I think, are a bit related. There's a theme running through both of them. So I'll run through the first two questions and then we'll go from there. So first question is, my liver function tests are all within the normal range apart from ALT, which is 37, so slightly higher, yet I still have very low energy. Should I not be feeling more energetic as my results improve? It's affecting my mood, so I can't do all the things I would like to without feeling exhausted and joints ache. And also a question about potentially taking some vitamin D. A similar question along that lines, a patient who's been on Urso for roughly 10 years, a responder, so their bloods are all in the normal range, but they do have a number of other conditions and also symptoms from their PBC.
Yeah, I mean, I think I'll do the easy one first, which is the vitamin D. There's never a problem taking vitamin D for all of us. Depending on where you are, we usually recommend around 2,000 units a day. It's certainly not, it's not dangerous, and it's logical that for your bone health, you want to have the building blocks for good bone health, and therefore you don't want to be low in calcium or vitamin D. So I think most of us don't get enough sunlight. So it's never a problem to supplement. As regards symptoms, that's always very difficult, isn't it? I mean, we know that PBC and other autoimmune diseases and other inflammatory diseases, be they of the liver or elsewhere, do cause symptoms, and those symptoms can be quite upsetting and distressing for patients because they impact the quality of life. Can you say which symptoms belong to PBC and which symptoms belong to other bits of you? It's not always that easy because many of these symptoms are non-specific. Do your liver tests being normal preclude you from having symptoms from PBC? Well, the simple answer is no. But that doesn't, that also, the flip side is it doesn't mean that everything is your PBC. So I think the best way to tackle these things is to focus on your general health, focus on your optimal PBC treatment, and doctors recognize that we can do well, and we recognize that blood tests are a good marker for the liver component of PBC, preventing cirrhosis and preventing the need to have a new liver. So that's clearly a focus, but we also recognize it's not the be all and end all, and it doesn't preclude there being an impaired quality of life from your disease or other things. And then what that then translates to is how to tackle it, because ultimately, tackling it's more important than pinpointing which aspect is the cause. And beyond having your PBC care optimized in terms of medication, then we sort of tackle the whole of you to look at those symptoms, and the whole of you therefore includes you know, your sleep, making sure you're not anemic, making sure your thyroid's okay, looking at your general health, looking at your exercise, looking at your diet, you know, checking that, you know, you've got the right social support, you're not feeling isolated or vulnerable, and tackling all of those things together to try and improve the symptoms, which are, you know, a challenge. And with that, I think people have found that you can be more optimistic, you can be more realistic. You don't have to solve everything, because, you know, we're not in a position to solve everything, but we don't have to be negative and we don't have to be fatalistic, and we can make a difference. And, you know, being on a platform like this is helpful, and having routines around exercise and healthy living is helpful. Does that mean we wouldn't like to develop, you know, a better understanding of why people feel the way they do? Of course we would. It would be very, very informative to know more. But at the same time, we've got to also be realistic. We know that PBC is very important to our patients and to us, but it also slots into many other parts of someone's life. So that's why I think ultimately, you know, the holistic approach is the pragmatic approach, and the one that actually gets you where you want to be, which is feeling a bit better. Hopefully over time that's sustainable. Hopefully having an understanding of why you feel the way you feel is also reassuring, and hopefully being reassured, particularly when one has so-called well-controlled PBC, that in fact other treatments and interventions are safe. There isn't a danger from getting the best treatment for, I don't know, thyroid disease, or the best treatment for depression, or the best treatment for anxiety, and there isn't a danger from exercising, you know. So part of our role is also to be a facilitator and to say, you know, if the best treatment is X, Y, or Z, the liver's not an impediment to getting the best treatment. And if all of those best treatments come together to make you feel better, then that's what really counts.
Yeah, and we like to think here at the foundation we can play a role in that as well by providing peer support and resources and information.
Yeah, and there's evidence that peer support in many different formats, regardless of the chronic disease, is helpful. So that there is data that's, you know, an effective intervention.
One of the general questions that I'd taken out of the previous two was, do PBC patients need to be careful with medications and supplements, and should that really be on a case-by-case basis? But I think when we're looking at someone, as you're mentioning about someone's overall health, we have to consider the other conditions as well. If they're looking for medication maybe for chronic pain or for allergies or that type of thing.
Yeah, I mean, again, you're not more likely to get a side effect of a medicine just because you have PBC. That's an important message, number one. It's true that if you are, you know, in the 25% of patients that come to our clinic with cirrhosis, we are a little bit more tuned in. But on average, there is no restriction to the medicines you need. And my advice is normally around prescribed and non-prescribed. And for prescribed medications, I just say, do you need the medicine, and is that the best medicine for you? So you know, that's the major sort of triage point for me. We're always more what's the word, circumspect about non-prescribed medicines, and that's not because we think you shouldn't take them. It's merely because we don't know necessarily if they'll help, and we can't tell you the side effect profile of every non-prescribed medicine, because we don't know, hasn't been developed, and we don't know the source of them. We don't know, you know, who made them, where they made them. You know, that doesn't mean we're, you know, at least I won't use the word we, it doesn't mean I'm averse to them. If people find some herbal remedies and some different teas and some different diets helpful, then that's great. I just counsel the patients to be realistic and to understand, you know, the risks and the benefits of something that we don't have that sort of backing. I mean, I think people should retain a high degree of confidence in the systems that exist worldwide to make sure that drugs are as safe as they possibly can be. And there's an enormous industry that goes into making drugs safe. It would be nice if that was the same for all herbal remedies, but it just can't be, because that's the nature of what they are. So we're not averse to them, And many of my patients are taking, you know, vitamin supplements, naturopathic supplements, different teas, etc. But I can't attest to everything because we don't know.
Mhm.
So it just requires you to be an adult and to be sort of sensible. But having PBC per se is not a reason not to take other medicines. Having cirrhosis for any etiology is, of course, a reason to be cautious.
Thank you. Just moving on to our next question, we've got a patient who was diagnosed over 20 years ago, been on urso, dose now 500 milligrams twice a day, but itching has not really been a problem until recently, mostly palms and scalp. Is this treatable? I thought it'd be worthwhile for us just to have a bit of a chat about the itch and what treatments are available for patients at the moment.
Yeah, I mean, of the symptoms that people living with PBC get, itch is probably the one that's most specific to PBC because it's a reflection of bile duct injury, a reflection in the change in bile acids, and a reflection of some form of bile acid driven, not necessarily bile acids themselves, bile acid driven irritability of the peripheral nerves in your skin, essentially, with your brain then amplifying those messages, which is why the symptoms of itch include a sort of sensation of, you know, ants under your skin. It's worse in your hands and feet. It can be worse at night. I mean, there are lots of patterns of itch, but that's a very sort of classical description.
Mhm.
And it's true to say that, you know, you can still get itch when you've got good disease control with ursodeoxycholic acid. In a recent trial, half of our patients in the study had significant itch, but had pretty good liver tests. So we know that it's not the case that there's a direct correlation. I mean, the flip side is true. The worse your disease, the worse your itch. Again, when you're tackling a symptom like that, the way I tackle it is to listen to the nature of the itch, listen to the severity of the itch, and listen to the impact of the itch. And there's lots of ways you can do that, some of which is listening, some of which is scoring. But ultimately, we come down to a conversation with the patient in front of us and say, you know, what would help you, and would you take a medicine for it? There are patients who don't want to take a medicine for it. They just would like to understand it because they don't, you know, they don't want another pill. There are some who just want to have instant relief and will prefer to go for antihistamines, even though they don't really tackle the itch of PBC. But for some people, pragmatically, they help them get a better night's sleep. And if that works, then that works. It's not saying that it's the perfect treatment for PBC itch, but if it's the kind of intensity of intervention that the patient wants, then that's fine. And then we have a cascade approach to managing the itch, which basically looks at your liver tests and looks at you and includes many different drugs, some of which have more evidence than others, and new drugs are coming. And you know, we presented a very big trial of a new drug for specifically designed for the itch of PBC. So with the entire intent that this is a drug to treat PBC and itch, and so that was quite exciting at USL. But I mean, we have lots of options. We have bile acid sequestrants like cholestyramine. We have, you know, drugs like bezafibrate, elafibranor, seladelpar, which treat the PBC and to different degrees can also treat the itch when you treat the PBC better. We've got the new drugs in development, linerixibat, volixibat in clinical trials, one phase 3, which is as close as you can get to an approval, and one phase 2, with encouraging signs that interrupting bile acid signaling does make your itch better. And then we've got other pragmatic approaches such as gabapentin. And alongside all that, we've got things like creams and, you know, other distraction techniques and other medicines. So I think the first thing and foremost thing is to be optimistic, not pessimistic. The second thing is to make sure that you had a chance to tell your provider that you do have itch. The third thing is to confirm that the itch makes most sense to be coming from your liver and not something else. I mean, you know, weathers change and you get dry skin. Some people get eczema. You know, there are lots of different things that you don't want to miss if they're a better treatment. And then to quantify the impact to you and to align that with how you'd like to be treated and to try things logically and not to do things too fast, because if you chop and change, all that happens is you don't actually work out whether it helped or not. So it does require a little bit of patience on the side of the patient, because, you know, you don't want to take something and then a day later say it doesn't work. Because if we think about, again, how this itch is being generated, and in my head, the way I think about it is it's irritable peripheral nerves. from a noxious chemical. Not noxious in the sense that it's harming your life expectancy, but noxious in the sense that it's irritating the little nerves and giving you this really very tedious and impactful itch that can affect your sleep and, you know, damage your skin from scratching. And then with the patient, we find that we can usually get an approach that works, and also reassure them that there's more than one approach, and they can sequentially try them to see what's good for them.
No, and I love that, because I think that often if patients aren't having a chance to speak about their itch, then the treatments aren't discussed. So I think it's important that they bring it up with their doctors and potentially look at anything that might help for that.
Exactly.
That's great, thank you. I've got a similar question actually around fatigue. Can a PBC patient become disabled due to fatigue and digestive issues? After having a meal, I need to lie down for an hour because I'm too tired and cannot function. I also cannot function during the first hours of the day or in the evenings. So just similar to what we did there for itch, just talk a bit about fatigue. Unfortunately, we know there's no magic pill for fatigue, but any treatments that might help and any strategies for that.
Yeah, I mean, I think, and we've talked about fatigue already, a very complex symptom because it's very many causes. And, you know, you can answer that and look at it in different ways. I mean, there's the optimist, which says, remember, if you take a quality of life surveys in PBC patients, more than half of patients have a good quality of life, more than half. Okay, so that's a very positive thing. And we shouldn't forget that there's a large number of our patients who are understanding their disease, taking their treatments and getting on with their day-to-day life. You can flip that round, and without doubt, there are some patients who are disproportionately impacted by fatigue or itch or abdominal discomfort. And then you can look in that subgroup of patients and say, you know, what is it about them that make them different? And is it their PBC? Is it another process? Is it a mixture? And as I said, what we do as symptom severity is at a higher self-reported sort of impact, we look at the individual patient and try and piece together where we think the drivers are for that particular patient. So do we occasionally see patients with debilitating fatigue? Of course we do. Is it the majority of my patients? No, it's not. You know, does that make it less important for that minority? Not. You know, so you have to make an assessment and you have to sort of individualize it. How we then tackle that, well, that's the challenge, isn't it? We definitely know that exercise helps. We know that patient support groups helps. We know that overcoming social isolation helps. We know that treating other causes of fatigue helps, anemia, thyroid disease, you know, low blood pressure when standing. And we know that the patients who have the best treatment for their PBC ultimately have the best quality of life. So those patients started on URSO as early as possible, in fact, have the best quality of life when you do the quality of life scores. Is that enough for everyone? No, there are some patients where it's not enough. We can also say reasonably confidently, unfortunately, liver transplant is not the solution. There is not a clear, consistent improvement in symptoms for liver transplant, such that's not an option to be looking at unless you need it for liver failure or severe itch. Are there new approaches to fatigue coming? Yes. I mean, and are there trials? Yes. I mean, reassuringly and quite gratifyingly, there are companies who are very focused on improving fatigue, be that specific anti-fatigue drugs in development, be that treating itch better. Alongside that, there are psychological approaches to the quality of life that I've also addressed, and there are studies ongoing to actually prove it, that psychological intervention, you know, actually makes you feel better. And at the end of the day, that's what counts. If it works, it works. So that's also quite sort of encouraging. There are some people who choose to use stimulants. It's not been a large part of my practice. There's a stimulant called modafinil. We've tended to not use that very much because of concern about side effects. It is exactly what it says, a stimulant. But we have had patients where we've navigated around their individual circumstances, their individual severity of disease, and their individual choices to try the use of modafinil to see whether that gets them out of difficult days when they've got other things to do, and allows them to overcome the quality of life hurdle that they're individually facing. But it isn't. I should be clear. It's an exception to my practice, but it's not something that I think is unreasonable if you are in the very small group of patients with the most debilitating of symptoms.
And I think as well, just what we'd mentioned there around it being personalised for each patient, because the symptoms can be very different for each patient as well. So it's really important for that personalised approach. At our conference last year, we had some physios in who were talking about a clinical trial that they're working on as well around movement as medicine that we've touched on as well. So that's really interesting, and those resources are available on our YouTube channel if anyone wants to have a look at them.
Yeah, I mean, I would say that when you think about things like physio and exercise, really you should be seeing it like a medicine. You should be seeing it like a diary event, and you should be trying to structure your day. And it's not to say that you may not feel tired after doing the intervention. It's quite possible you do. It's not to say that at the beginning of starting to do exercise that you will be running a 100-meter race or a marathon. But even doing a small amount on a regular basis and not giving up and then taking a nap is actually beneficial. So you have to see beyond the mountain in front of you and look at the hill on the way down, and recognize that this has to require some persistence to make a difference, and it then does make a difference if you take that approach. If you take the approach that you can't do anything, then unfortunately that's not going to help you, and that's why you might feel like that, but it's just not very good advice. Because if you start to decondition your muscles, and then it's just a bigger battle to overcome. So there has to be an optimism to tackling the most severe of symptoms, and really an effort to, even if it's only a small amount of exercise, to really sort of to add that to your schedule, because my experience is that that's actually very helpful. And at the same time, if you're so symptomatic it's affecting your mood, which is not uncommon, then if non-medical interventions aren't helping, there should be no concern or shame about saying, is there anything medical that might help me? Because if that opens the door to letting you do the exercise, well, then you won't need the mood medicine again after a while, because you would have moved back into doing some exercise. So sometimes breaking cycles, where it feels like everything is too much, takes an extra effort. And finally, that would be where patient support groups, wherever you are in the world, can be very, very helpful, because they can just give you this external validation and this external sort of opportunity to try these things and to see the benefit.
It's the investment in your energy, isn't it? It's not going to happen overnight, but it's something that if you invest in it over time. Just to mention that we do, and as you mentioned, the local patient support organisations have groups as well. We do a self-care session every Tuesday, which we call Choose Me Tuesday, which is hosted by Cheryl, and it talks about those type of things, and also the importance of looking after yourself and the benefit of not just the exercise if you're taking a walk outside, but getting out in the fresh air and that type of stuff as well.
Exactly.
Which is all great. So I've got a few questions on OCA now. So I've been taking OCA since October, the second line, because my bloods were starting to rise. I'm lucky to have no other side effects, but my bowel habits have changed and I need to go 2 or 3 times a day. Is this something I should be concerned about? I've had stool samples checked and no worries there.
I mean, broadly speaking, I don't think a change in bowel habit has been reported to be associated with obeticholic acid. Indeed, actually, the science of obeticholic acid suggests that it's actually quite good for your colon health. Does that mean on an individual basis people don't see a difference? It's possible. Remember, the best approach to treating PBC to date, despite it being an autoimmune disease, has been to modulate bile acid. Ursodeoxycholic acid is a bile acid, obeticholic is a bile acid, and the PPAR agonists, that's bezafibrate, fenofibrate, elafibranor, seladelpar, are all interfering with bile acids. And bile acids are clearly related to your colon health. There's no doubt. So it's not inconceivable that any of these therapies might, for different people, be relevant. There's even a disorder which is, which is really a variant of irritable bowel syndrome called bile acid diarrhea. So I'm not suggesting for a second that it is a simple thing, but in my clinical experience, it's not been a major feature of OCA use that's caught my attention. So normally in those situations, we recommend you talk to your family doctor, make sure that your colonoscopy screening is up to date, and then to look at how it disrupts you and whether or not you need any intervention like loperamide.
Great. Before we just move on to the next question, I've just noticed in the chat here, we've got just a little question about when we were talking about the anti-fatigue drugs in development, just if you had any other further information that you could share about that.
Nothing specifically. There's a company, I think based on the Karolinska in Sweden, that's been doing a clinical trial. I think Professor Jones in Newcastle has been quite involved. It's a drug that's interfering with a neurotransmitter in your brain that's been looked at in a number of sort of conditions where there are symptoms thought to be relevant. That's one approach. Some of the other data from EASL, which was this big liver meeting we went to, was seeing whether treating itch better can make fatigue better. So I think your provider should be able to signpost you, and usually most patient support groups have a website where you can find all current clinical trials. Obviously, it depends on where you are as to what's available. So that's often a way to navigate the latest trials and to see whether you can connect to those investigators.
Yeah, the first trial that you mentioned there about fatigue, we've been helping support in that trial, so I can share some information. If any patients want a wee bit more information about where that's available in the UK, if they pop an email to me at mo@bbcfoundation.international, excuse me, I can help with that and circulate some information as well. So, right, back to OCA. So I'm currently on OCA in America, but will be retiring to Europe. And as OCA is now no longer available in Europe, what have PBC patients in Europe done? Has their doctor changed them to the new medications available?
I mean, that's a good question. I think it depends on where you are in Europe. Obviously, UK is different, but it's correct. The European Medicines Agency revoked the license for obeticholic acid, and to my understanding, that means that new patients are not starting on obeticholic acid. Depending on where you are in Europe, there's been different approaches to existing patients, and I think you have to talk to your local provider to understand every different country. We're lucky. We're unlucky to be in the situation where a drug that many of us feel is having a good impact for many of our patients is differentially available. It is available in the UK, it's available in Canada, it's available in Australia, and it remains available in the US. And it really just shows the challenge of making new drugs for PBC and this whole journey from the disease to the societal effects and to how you sort of develop new drugs for every disease. Mm-hmm. So are doctors giving up? No, they're not. So in different, depending on where you are, doctors are using other drugs. So many doctors have been using drugs such as what we call the PPAR agonists. And the PPAR agonists really, depending on where you are, there are those that are not approved, and that's historically bezafibrate. And then there's those that are approved. And again, depending on where you are, they're at different stages of approval. But the two new drugs are Elephanor and seladelpar. And I'm quite sure that the doctors looking after PBC are aware of those drugs and aware of the prior drugs, bezafibrate and fenofibrate. So I'm quite sure that people are having the option, if they can't get obeticholic acid, to try some of these new, different approaches and new and different depending on where you are, to control the PBC. And I'm quite sure fortunately for many and perhaps the majority of patients, this will be a good solution. So I would not be, I wouldn't be pessimistic. I'd say that there are options, but the only thing is to navigate those will depend on where you are and working with your local specialist to sort of identify what's best for you. We would also say that ursodeoxycholic acid remains an anchor and a good basis for our treatment of PBC. So we're not asking patients to stop that. We're asking patients to continue it.
Yeah, just to say, we have an article on our website, a news article on our website that we've been keeping up to date with when the new medications have been approved in different countries. We're keeping that active. We've also recently updated our treatments page as well, so it includes the new medications that you mentioned there, Elephanor and seladelpar. And if anyone has any specific questions about that, you can reach out to us as well direct.
Great.
So next one is, in 2023, I started with itch symptoms, was put on Ursol, but itch worsened. I was then switched to OCA, and I've been on this for over a year. But ALT is getting worse. Last month, ALT was 1012, and GGT 565. I've reduced OCA to 5 milligrams from 10 milligrams due to severe itch, and at my last review, they are considering trying Elephanor. Please advise if this should be used in addition to OCA or instead of, and do we think this is the right or most effective course of treatment?
Well, obviously, I'm not going to give specific advice to the level of that question, but I mean the general position would be that people looking after patients with PBC believe that you do need multiple drugs to control PBC, and that's why many of us have advocated for obeticholic acid and PPARs, be that bezafibrate, elafibranor, or seladelpar, depending on where you find that you live with PBC, because there are differences, and there are even differences across countries in what you can access. So if a drug's not working, then that's a sign that you generally can switch, and I think we will be seeing some switching if a patient has got persistent treatment insufficient response plus symptoms. And then many people will be switching. Combining drugs, well, that will take time. They've not been tested together. So have we given bezafibrate and obeticholic acid together? Yes. And for example, we've given that to more than 50 patients, but we don't have any data on elafibranor or seladelpar in combination with obeticholic acid. It hasn't been tested in a controlled setting. So I think that as new drugs come to market, you are wise to be guided by your provider and where you are to do the safest option for you. And so it may well be more likely that a provider will go for the new drug and not the combination, because they want to learn about the new drug, see the benefit, and make sure that they don't do any harm. Do I expect there to be any issues between seladelpar, elafibranor, bezafibrate, and obeticholic acid? I don't. Do I expect there still to be people who need to have multiple drugs? I do. Does that mean that we want to be sort of gung-ho and rush ahead? Probably not. Just because that's just, very important disease, but it is a lifelong disease. We don't want to make things worse for our patients inadvertently. So I think you work with your physician, and my advice is always make one change at a time so you can see whether or not the benefit is there for you, and then you can understand whether the benefit changed. And if you make too many changes at once, then you you get confused essentially, and you really don't know. Will the new drugs have side effect burdens? Yes. Okay. Do we think there'll be a different side effect burden to obeticholic acid? We do. But again, you have to move, in a logical and conservative way from trials to new drugs. So I would say that for someone who doesn't have, sufficient response to obeticholic acid, that's disappointing. But we have other options, and likely is we'll be trying those options alone before combining. And then finally, you have to, depending on where you are, you have to live in the real world about reimbursement. And that's different everywhere. In the UK, it may be more linear. In the US, Canada, elsewhere, it may not be as simple to combine drugs. Someone has to, cover the costs, because we obviously don't want our patients paying for the medications. So that's, again, a sort of a genuine, pragmatic, real world thing that you discuss with your provider.
Thank you. Our next question, patient 44-year-old woman, had abnormal liver function since 2013 and has been observed for years but never received treatment. During this time, they've had 2 liver biopsies, lots of fibroscans. Their only symptom was fatigue. The only time their blood tests were normal was during their 2 pregnancies. So they have a lot of questions around the links with PBC and hormones and PCOS, which I also have, curious of the correlation. Is there a link between PBC and hormones?
I mean, that's a great question. I mean, by definition, yes. And the definition is that whichever way you look at it, PBC is a female predominant disease. Whichever way you look at it, it tends to be in women closer to the menopause, and whichever way you look at it, it's exceptionally rare in women under the age of 18 or under the age of 16. That's not to say it never happens, but it's exceptional. And the majority of our patients are over the age of 50. We do see younger women. The other thing that I think is very relevant is that we know that if a woman does get pregnant with PBC, then we can see extra itch and extra what we call cholestasis from during the pregnancy. So, I mean, I think on face value, that's enough to say that there's an association between PBC and hormones. How that plays out in everybody, we don't know. I mean, we don't have those answers. We know that in certain circumstances, the hormone interaction makes it worse. So I'll give you that particularly during pregnancy, patients with active PBC often get more itchy. Not everyone, but that's what we see. So yes, there's clearly something around biological sex. I mean, obviously that's just a biological description of what we see. Do we understand it all? No. How does that impact the patient? Well, I think it does impact the patient. When I think that my practice is predominantly female, I think about, what do I see in practice which bothers our patients? What do they tell me in clinic is their concerns and their symptoms? I'll tell you, women with PBC get more urinary tract infections. That's a fact. Okay. Urinary tract infections are common in women, but women with PBC get more. So that's something we can tackle, okay, by being aware of it and treating it. Women with PBC get more mucosal dryness, and that can include gynecological dryness, and that's something we can tackle. Women with PBC, quite rightly, may wish to conceive, and we can help them in terms of managing the pregnancy with giving good advice to their obstetrician, reassuring them about the safety of ursodeoxycholic acid, telling them what drugs they should and shouldn't use during pregnancy and during breastfeeding. And then finally, there's two other things. Women with PBC may wish to have HRT, and we can reassure them that it's safe to use. And women with PBC, particularly postmenopausal women, may be at greater risk of bone health and bone mass loss, and we can guide them in that direction. So we recognize it. We see the clinical consequences. Our science is behind the clinical consequences. Is it the X chromosome? Is it the estrogen effect on the biliary epithelium? Is it something gynecological about microbiome and bugs? I don't know. I mean, and there's probably a ton of research that we'd like to do, but it's just been a little bit sort of overlooked as a topic. But can we give good, solid advice about what to do? Yes. And is it worth taking the time to discuss it with your provider? For sure. Because again, it's a quality of life thing. One of the things we've just been, we've had a poster on, it's very common for patients with autoimmune liver disease, particularly PBC, to have dryness, particularly often, mouth, eyes, but also vaginal dryness. And what we found, actually, interesting enough, is that dryness, mucosal dryness, not skin dryness, mucosal dryness, is associated with fatigue. Okay, so again, does that give you the answer? Maybe not, but does that information help someone live with the consequences? Yes, because for all of us, we're seeking to just understand our experiences. We don't necessarily seek, we would like perfection, but most of us are pragmatic enough to know that there isn't the perfect pills for everything. But at least understanding how and why you feel, what's linked, what's not linked, what might exacerbate, what may not exacerbate, what's safe, what's not recommended, really does help in the chronic disease setting. I mean, we're talking about living with disease for 20, 30, 40, 50 years, and getting on with life and doing all the things that you want to do. So every nugget of knowledge, in my opinion, really does actually help you just get on with things, even if it isn't the perfect pill. It validates how you feel. It helps you understand the concepts. It helps you advocate in a nice way when you want to raise something and discuss it. And I'd say that's a definite pro.
And I think when you touched there on validation, I think that's huge for us as patients. So when we mention something like that to our doctors, just for that to be validated and us to have a bit of a conversation about it. Again, we know there's not necessarily a magic pill, but just chatting about that and it being accepted as a bonus as well. Right, on to our next question. So apart from bloods, what tests do you recommend having, ongoing scans, etc., and how often? So I thought we could talk a bit about the recommended regular monitoring tests and a bit about our resources that we have here at the Foundation, but also the care pathway.
Sure. I mean, I think, again, you individualize this to where you live and who looks after you and what's accessible, and that's not the same everywhere.
Yeah.
In essence, most of my patients see me at least once a year. Some patients see me more, depending on their stage of disease or their symptom burden. And most patients are getting a panel of bloods, and most patients are getting a FibroScan somewhere between every 1 to 3 years. And a FibroScan is like a liver health test where we tap on your liver by some device. With FibroScan, elastography, it really doesn't matter. And depending on where you are, you'll have different access to different tests. And that's giving us a sort of liver health, liver scarring assessment. So that's what we do as the mainstay, alongside asking you how you feel. Do we do ultrasounds sometimes? Usually that's in patients with cirrhosis. We'll do an ultrasound then, and we'll do that more often if they have cirrhosis, up to every 6 months. Do we look after bone health? Yes. We don't actually recommend more bone health, but we nudge you in the direction to make sure you're not getting less than you should have, and that your family doctor has connected you. Do we advocate being on top of thyroid, making sure there's no celiac, checking anemia? Yes. Again, on a sort of 1 to 3 year basis. There's not proof about how frequently. In my experience, if you do all of those things, you'll capture the most important part of surveying the disease. And also you'll capture when things have changed. If someone's developed cirrhosis, then that opens up a different pathway. Cirrhosis care is defined not by the cause of the cirrhosis, but by the agreement that there is significant scarring, and that triggers a different sort of routine of bloods and imaging, usually maybe up to every 6 months, depending on where you are and how you interpret the guidance. Is it helpful for patients to be on top of this? Of course, and things like apps and tracking your bloods and using. So we use a program called Epic. So our patients can see all of their blood results, all of their appointments, all of their FibroScans, all of their notes, and can track everything through their phone. And increasingly they're connected to all of the hospitals that they go to. If you're in the US, you can. If you're in an area where everyone's on the same EMR, then you've got a completely linked healthcare. That's some hospitals do that in the UK, some do it differently in Australia, et cetera, et cetera. But I mean, so we're very much about removing the barriers to tracking what's going on, and contributing to your understanding of your disease, the right tests at the right time. No one wants more tests than they need. It's not actually in your interest to have more than you need. It's time off work. It can be inconvenient. There can be discomfort. So you want what you need, but you don't want less, but you don't want more. So we found that to be good. I mean, as to care pathways, again, I really think that depends on where you are.
Yeah.
It's easy to write a care pathway. It's a lot harder to implement a care pathway. Some parts of the world, UK, it might be more linear. Other parts of the world, Canada, I think care pathways are very difficult to implement because care is delivered in a completely different way.
Yeah.
And you've got to have a pathway that reflects, where your care is delivered.
Absolutely, yeah.
It's not actually helpful to have a pathway you can't follow. It just causes you stress. So we don't want that. That's not contributory to good care. So look at where you are, talk to your GI, your family doctor, your hepatologist, and address your care pathway in that way.
And we do have some resources that can help with that are patient versions. And we're also working with the other patient support organisations around the world to look at country-specific ones as well, so that it can be more specific to the area that the patient lives in as well. So that is some work that's been going on in the background in terms of getting those translated, but not just translated into the local language, but also into the local service provider area as well, which is really important. One other sort of general question that we had, and it was just something that when I was thinking about there when you were talking about the hormones, is that a question that we often get asked as well is PBC genetic? We do see some families where there's history there, and then questions follow around that, thinking if you have a daughter, should you suggest that daughter gets tested, or what are the best options for that? So I wondered if we could just chat a wee bit about that.
Yeah, I mean, it's a good question. If you take 20 people living with PBC, then usually 1 in 20 have got a family history. And that's usually a female family history, but it can be men. And we have all sorts of family histories. We've got boys with PSC and girls with PBC in the same family, and we've got mothers and daughters and grandmothers and daughters and mothers. It's not that common, but it definitely happens. So my approach has been to look at the age of onset, to look at the individual family history, and to look at what the patient wants. I don't routinely screen children because the yield is low. But if someone's got a strong family history of PBC, then I do talk to them about it. One of the things about screening is, which makes it more complicated, is it's not a one-time screen. And so, you screen someone age 40, and because they haven't got PBC then, doesn't mean they might not have it when they're 50, 60, 70, or 80. So you do need to sort of think through how you're going to do that, because that's a different kind of screening. It's not like I can do a genetic test and say you will get PBC. That is not available. It wouldn't be meaningful, and it's not a reflection of the science. So screening for PBC from a family history is all around doing blood tests and anti-mitochondrial antibodies. But a screening at one moment in time does not mean you wouldn't get it in 10, 20 years, because we know that autoimmune diseases come on different times. Some people develop celiac later in life, some people lupus, some people PBC, so you do need to then sort of address with the patient what it means, because you don't want to say, oh, well, you were tested once and that's it, you're never going to get it. So my approach has been more around education, around people being aware within their families about PBC and what the symptoms might be, than it has been to say you definitely need to be screened. For some patients, we've done that. For the patients, but that, as I said, really has been for the patients with very strong family histories or very early onset, and lots of other autoimmune diseases in the family. So it's important, but it's not something that the majority of people probably need to spend too much time worrying about. You're not going to change your genes either. Not yet. We don't have that technology. You are going to statistically look like your parents. And if your parents have autoimmune diseases, whatever they are, then the chance of you having autoimmune disease is increased.
Yeah. I've just seen a question pop into the chat there. Now, we did touch on EASL earlier on, but I think it was more just when you and I were first catching up before we started the session. Unfortunately, I didn't get to EASL this year, which was really disappointing, but we did have a number of the team there who reported back on there being a lot of PBC in the event schedule, which was brilliant. Doctor, do you want to talk a wee bit more about that, just as a general one for the rest of our viewers?
I mean, it's always a busy meeting. There's always new science and more knowledge. I think in the PBC space, we really had lots of education about the treatment of PBC, different drugs. We had new data on the use of those drugs from trials and in the real world, which is helpful, and long-term learning about the different drugs that we have: obeticholic acid, bezafibrate, elafibranor, seladelpar. I guess a highlight for me was I was able to present a phase 3 clinical trial. So that's just before you apply for registration of a new drug specifically for itch, which we mentioned. So, we were pleased to present the positive results of that trial for a drug called linarixabat, which is designed specifically to treat itch. And so, it was gratifying to see that our patients took part in the study. They were recruited from all over the world, I think 4 continents of the world at least, and the drug was efficacious. The other things I think that was gratifying was continued collaboration. So UK PBC, global PBC, Italian cohorts, Spanish cohorts, demonstrating their data from their databases on PBC, showing that your blood tests still mean good things even when you're on drugs like obeticholic acid or bezafibrate. So they still work to predict your outcome. So lower is better for your blood tests. So I think that was also reassuring. And then finally, we actually started the conference with a one-day meeting where we spent a lot of time and energy discussing how to keep making better and newer and long-lasting drugs for PBC, because it's not easy. PBC is very important to everyone, with patients and investigators and pharma and healthcare regulators. But at the same time, it finds itself in the real world, and there are thousands and thousands of diseases as well, which all need new drugs. So you need to have rules, and you can't. But you want those rules to reflect the individual disease as well. So we spent the whole day discussing how to make drugs, what the process should be to make a better drug for PBC, to make a drug that stays on the market, that addresses the questions that a patient wants to know. A patient wants to know, does the drug benefit me? And the patient wants to know, is there any potential harm? Okay. And it's not easy for a rare disease that goes over many decades. And, always reflect, it took decades and decades to get to where we are with ursodeoxycholic acid. And that's considered a relatively benign drug, but it's obviously good. But it wasn't even easy for ursodeoxycholic acid, let alone these newer drugs, which have been giving in milligram quantities, to sort of get across the line with all the data we need for efficacy and safety.
And just touching on what you said there, so you mentioned UK PBC and global PBC and the issues that we've had with OCA, which was withdrawn because of the issues with the placebo in the trial. I just wondered if it's worth touching on that and the importance of gathering the data potentially for real world evidence.
Well, I think the bottom line is we need data. I think the reasons why OCA was withdrawn in Europe, but not elsewhere, is a very complex regulatory science and legal framework that really, is a reality, and it's one that we're advocating hard and strong to adjust in a way that's positive for patients. But I will say we don't want drugs that are not safe.
Nope.
And we cannot compromise on that, because if you compromise on that, that's not good for patients with PBC either. So placebo will not disappear, but the use of placebo needs to be proportionate to the need, and it needs to address the right questions at the right time in a drug's development. And that development of a drug really goes on for years. I mean, there was a presentation of a new drug potentially for PSC that's been in development for 15 years. It's not quick. It's incredibly rigorous, and all designed to show benefit and no harm. So I think we all agree that we need to keep advocating clearly. We want effective drugs, and we've got some good ideas about needing to have different classes of drugs: FXR agonists, which is obeticholic acid; PPARs, which are seladelpar, elafibranor, bezafibrate, fenofibrate, and to have a mixture of evidence from a mixture of places that it answers the questions at different times in the development of a drug around, does it help and does it not do any harm, and can you use it for a long term? And that definitely means that beyond the classical trials, where they're literally highly controlled events, that we have to use what we call real world data, which is what happens in clinic. But that is very important, but also very hard to capture everybody's experience, to align that experience to where you are, which country you're in, the healthcare that you're in, how a treatment choice is made, how and why. But if we do it well, which I think we will, and we are going to get better at it, and we work collaboratively, and in a rare disease, that means working across the world. No one setting can really answer it just because of the frequency of the disease. Then we can really present good real world data at a high level, which answers the questions that patients want, it answers the questions that regulators want, it answers the questions that providers want, and it answers the questions that pharmaceutical companies need. And that really, I think, is absolutely essential. But we would be naive to think that we're the only disease that has to fit in And whatever we do needs to fit into this bigger system of making drugs, where it's absolutely essential that that bigger system, the patients and the public retain trust. Because we're all going to need different drugs in our lifetimes, whether it's for our blood pressure, whether it's for our cholesterol, whether it's for our mood, whether it's for our PBC, whether it's for our heart, whether it's for cancer, whether it's for skin, whether it's for our kidneys. And we all put a huge trust into that system. Yep. That when we pick up the prescription, maybe most of your listeners today are from the UK, you go to Boots and you pick up your prescription, you believe something when you pick it up. And that's why you take it. So it's a real sort of important thing where we want to be high up on the advocacy for PBC, but also high up on the advocacy for a system that really is going to be good for all of us for decades and decades. And so I think we know what we need to do. I don't think there's a shortage of advocacy. There was a lot of new science from all sorts of things at EASL. So I don't think people should be pessimistic. I think people should be optimistic. Does that mean we need the support of our patients? For sure. I mean, we need the support to use your data when you've given permission or without retrospective, and it's all de-identified. That data is gold dust. We can't answer the questions if we don't have the data. Yeah. So again, and that's also based on trust.
And that's something as a patient organisation we try and inform our patients on. At the first International PBC Summit, Bettina Hansen was there with us, and she quoted something which I've used so many times since then, but how us as patients can give a gift to future patients by allowing for our data to be recorded. Obviously anonymised and all of that, but just how our symptoms are and what medication we're on. So and I think that we would all buy into that,
Exactly, because and the higher the quality, the more the information, the more the people who are responsible for maintaining the safe drug system, and that's a huge responsibility if you're a regulator. Okay, you really believe you do that job because you want to do the best for people, and there's no regulator that wants to stand in the way of an effective drug, but there's also no regulator that wants to be the one that says, "Well, why did you let this one go through?" And so we make their job better, and it makes it a better collaboration. That's why in the room were regulators, were patients, were clinicians, were pharmaceutical companies. Everyone's got to be in that boat together.
And we want to make sure as well that as patients are taking their time to share that information, that we're getting the right information, so that we're making the most of the data that can be taken as well, which is great.
Sure. Okay, I think we're getting to the top of the hour.
We are just getting ready to close up there. So I was going to say thank you so much to everyone for joining us today. Thank you so much for your time, Doctor. It's been really appreciated. I'll be in touch about arranging another session as well. If you've joined us live, thank you so much for taking the time to do that as well. I'll be uploading our session onto YouTube following that as well. And remember, we're here if you need us for anything, for any more specific advice or any urgent support. We're available on the helpline. We're here for you. Great. Thank you so much for your time.
Have a good day, everyone. Bye-bye.
You too. Bye. Thank you. Bye.